Good evening. John Young, the Chair of the Finance Committee. I'm going to call our Committee of the Whole to order. Sheila, can you call a roll, please?
Mr. Furman, he gave notice he was not able to attend. Dr. Giles?
Here.
Pastor Jones?
Here.
Dr. Guadalupe?
Here.
Ms. Woodruff? Dr. Hans?
Here.
Ms. Newman? She's present. She isn't here. Yeah. Ms. Root? Here. Ms. May? Mr. Torres? Mr. Cowan? Present. Mr. Young?
Here.
We have a quorum of the Finance Committee and quorum of the Policy Committee.
All right, thank you. This is our first opportunity for public comment. Anyone online wishing to speak?
If you are online and wish to speak for public comment, please raise your hand at this time.
No. Okay. There'll be another opportunity at the end. Anyone in the room wishing to speak? Again, there'll be an opportunity at the end of the meeting. 1C, I need a motion for approval of tonight's agenda. So moved.
Second.
All those in favor by aye? Aye. Opposed, same sign. Okay, we have an agenda. First up, Finance Committee. 2A, our January 2025 financial update. Robert, can you walk us through the financial PowerPoint and income statement?
Good evening, everyone. So we'll start off with our revenue. You can see that it's relatively flat for the first 4 months of the year, a tiny downtrend. I do want to emphasize that in reporting our revenue, we're on an accrual basis of accounting, so our cash receipts don't necessarily align with our revenue because some of that revenue is actually paid out to other folks, and rather than coding that as an expense, we reduce the revenue amount, and that's predominantly related to the CCBHCs. So I wanted to make people comfortable with that. Our revenue overall is up for the year, and that's some good news. Next slide, please. You can see the trend in our eligibles, which drives our revenue to a certain extent. That is slightly downward trending and consistent in terms of that trend with the prior year. Next slide, please. Overall, our balance sheet is on the asset side is fairly consistent year over year. We do have a decrease in our overall assets during that period of time. And you can see sort of like a shift in the cash versus the receivables, but in total they're somewhat comparable. And then again, as I note pretty consistently, you see that downward trend on the capital assets, which is just a function of the depreciation that we're booking. And on the liability side, you can see a slight increase overall in our payables out to our vendors. On the balance sheet side, you'll notice a change in our overall net position between September and the end of January. In the neighborhood of close to $6 million, $5.8 million. We're, of course, cognizant of that and working to get that under control. I do want to note for the record, we had a meeting with the providers and notified them that we were expediting the transition to fee-for-service, to full fee-for-service. from the original projected date of October 1st to July 1st. So we'll gain an additional quarter of the opportunity to be on fee-for-service, which we believe will contribute to reduced overall costs relative to the payments on the service models. For our overall revenue, you can see that increase that I referenced, about $157 million in total revenue coming in for Medicaid. Excuse me. The other revenue is relatively consistent and nominal, or, when compared to our Medicaid. And obviously, that's our number one revenue stream. On the expense side, we're paying out about $158 million, and that contributes, that difference between the revenue and the expenses can be seen on the next slide, our net income slide, where we've got a decrease, a deficit of about $5.9 million. An improvement from last year. I think that's worth noting for the first 4 months. But still a pretty significant challenge that we face, which I believe that we knew. And we're, again, as I referenced, making efforts to correct that. Does anyone have any questions relative to the graphical presentation for the...
First from the Finance Committee, Sarah?
Yeah, I guess not necessarily to the graph, but you had made mention that the fee-for-service model would change beginning July instead of October. Are there any, have you received any pushback or issues from folks regarding that change?
I think that there was generally a warmer response, candidly, than I had expected. I don't know that people are excited about it, and I think that's been people, meaning predominantly the providers, and I think that speaks to the challenge that we're trying to get our arms around, which is that we should be paying on a fee-for-service basis. And I think that does two things. Again, keeping in mind, like, our mission of ultimately, like, serving people. I really feel like it's more visible, it's more transparent on a quantified basis exactly the services that folks are getting. I think that in the service models, a well-intended exercise, right? I think that it's difficult for us to tease out exactly what services are being paid for and provided. And we do have encounter data. I don't want to overstate that, but fee-for-service just makes it much more transparent, much easier for us to get our arms around what we're paying for, if that makes sense. So, I think there was some mild pushback, and I think that there's an acknowledgement on the part of providers that they may have to change how they're conducting their business.
Okay. Probably a better question I should have asked too is, do you foresee any issues with compliance from the providers?
No, I don't think so. I think that the challenge for us going forward is developing rates, publishing and making those rates accessible through our billing system to the providers, and then considering feedback that we get about the reasonableness of those rates, and considering it on kind of both sides of the equation. We want to make sure, like, our goal is not to inflict pain on anyone, right? But we have an ability to pay. We have a certain pot of resources that we have available to us, and I think that we've talked on a number of different meetings about the funding challenges in the system as a whole, and we have to live within our budget. Is really what it boils down to.
Great, thank you.
Thank you.
Any other questions? Pastor Jones?
Robert, a couple of things. One, I like the idea of how you're dispersing the revenue. That has been an issue of what was paid out, what we had, and what have you, from the first statement that you have made. But I'm looking at the net income comparison, and good to see that the deficit is less than what we expected. So that's good. On the early projection for this year, I think we were projecting that we may end up in a plus column. maybe not by much, but maybe a plus column. With the new calculation that you're saying, and looking at where we are, and this is a three-part question, looking at where we are, do we still think that we may end the year, October 1, in a positive position, taking into account, this is the third part of that, taking into account the anticipated cuts that we may receive based on what's happening in Washington with Medicare, Medicaid?
Sure. So I'm going to answer that from a couple of different perspectives. The first one is this, again, I'll go back to that system as a whole. I participate in a forum that includes the CFOs from the other PIHPs around the state. And at this point, not all 10 have reported, but of the 6 who have reported, all but 1 are projecting a deficit. So I think that's important to note, and I think it speaks to the fundamental systemic problem. The second thing that I would say is that 4 months into the year, while we've improved from the prior year with a $5.8 million deficit, I think it would be unexpected that we would end up in a positive position at the end of the year, but not impossible. I would not forecast that. Yeah.
Yeah. So in that, even a snail's pace sometimes seems fast. And in relation to what our deficit has been in the past, any improvement would show some positive trend.
Yes, I mean, right. We'll take all the help we can get. We'll take all the positive news we can get. No question about that. The other thing that I want to qualify is that there are cost settlements that we're still working through finalizing, and there's potential opportunity there to contribute to some funds from prior years, which would then give us more flexibility in terms of this year and future years. Would give us more financial stability for sure. And there's a lot to be determined there. But I guess I'm saying that to say that there are some bright spots. There are some things that we're working on and continuing to work on to improve our overall financial outcomes.
Well, I think the early adjustment that you made, I think that's good that you talked about that. Thank you.
Thanks.
Okay. Dennis?
Robert, thank you. So I'm looking at the statement of revenues, expenses, and change in net position, budget to actual, because I've always been a budget guy. So that's where your $5.8 million number is, because we've got $164 million, or almost $165 in revenue, and then we've got, unfortunately, $170 million plus in expenses. So that's what creates the deficit. But if we go all the way down that line, we had forecast a $10.4 million deficit, and so we're to the good against budget, which only means something to those who pay attention to it, of about $4.5 million. And the reason I bring that up is because if you go to administration, which we can control, that's our money, the expenditures here. We're in a net positive position so far in those 4 key categories of salaries, fringes, facilities, and others. Now we'll save for another time a discussion of what other is and whether or not that'll hold up. But from looking at this snapshot for 4 months, we're in-house, we're controlling our expenditures. It seems the line item that jumps out is the mental health and IDD services, because that's almost $10 million. It's all right there. It's all right there. So
yeah, and I'm sorry, if I could just editorialize on that for 1 second.
No, please.
The majority of that is general fund dollars. Like our challenge is in general fund dollars. And I would also add to that, we're using general fund dollars because Medicaid funding is not sufficient. I mean, it's all tied together.
Right. So we've got to, obviously, that's the goal, and that's what would be impacted by the fee for services. Yeah, and so, and I got some other comments, but I'll save those for after the meeting on that situation. But Clearly, it's better than we thought it was going to be, but still not where we want to be. And I think you said that. Our goal still would try to be to balance this out, but we're going to need a little help. And I know it's in a very discouraging environment because the Washington D.C. is talking about cuts. We've got other challenges now with the department, so we're just going to have to work through it. But we're holding our own, and it's not like my father used to have a saying that he thought he saw some light at the end of the tunnel, and then the whole blank thing came down. So I think the tunnel hasn't collapsed. We can still see some light.
Yeah, definitely. I do want to emphasize for the board, if we look at the balance sheet, one of the I'm sure you're familiar with this, a fairly common sort of like ratio that organizations look at is their current ratio, which is your current assets to your current liabilities. And we're at about a 1.25 to 1, which is fairly, it's robust for a nonprofit, but it's also what I would consider to be a thin margin. So I just want to emphasize that we have some ongoing challenges, and we are addressing them.
Right.
But
Well,
we
thank
need to
you.
be just mindful of the challenge.
Right. No, I get it, and we appreciate the work you're doing along with many others. I mean, this is almost, the entire organization is trying to pay attention to this. So thank you very much for that update and answering my questions.
Yes, sir. Yes, thank you.
Bill Kaya.
Thank you, Robert. I was wondering, have we heard anything from the state about the difficulty of classifying people in the wrong pot? Have they responded at all? Are they saying anything at all?
We have, like our CIO works with the CIO group, and they are aware. I don't believe that a strategy has been considered yet. And the other thing is, because of what's going on with the state at the state level, we haven't had consistent meetings with them either. So in order to address that, we've been meeting as PIHP, CMHSP groups, but in terms of having those consistent meetings with the state, they haven't been there in order to make that really known to them. I think they're aware, but in terms of a plan to address it, nothing yet.
Any other questions? So, Robert, I've got one. For the cost settlements, are those predominantly with the state that are still out, or with the providers, or both?
They're predominantly with providers.
Providers, okay. And then, so if we roll back to the liability comparison slide. There we go. My question on the change due to the state. Can you take a second and, I mean, it's a relatively large amount, yeah.
Sure. So in our FSR for the last year, we posted about a $6.3 million receivable from the state.
Okay. And since Mr. Cowan went deep on the budget sheet, the category of mental health and IDD services is enormous. Maybe a question more for Dana or Trish or kind of the executive group. Is it worthwhile breaking that out, or is that's the category that the state uses? That just seems huge.
That is something that Nassar has reported on in the past in terms of the Medicaid group IDD or mental health. What I think you're really asking is whether or not they break it out in terms of DABs, TANFs, and
well, yeah, it might be helpful to see that kind of, because the number is huge.
Yes.
And so on the one hand, the 9.8 million looks like a big off, but depending on what's driving it, it could kind of open up a whole other host of questions.
And then the other thing about breaking that number out is that it fluctuates so much, as you've seen in Nassar's reports. That can change month to month.
Oh,
so
absolutely, yeah.
it may present one way in one month and then another way. I think the data, if you can see it over time, shows probably a better picture, but then it makes it even look even bigger in terms of the number of people we serve. And I think we saw that at our board study session.
Yeah.
So I think they had a suggestion on how we can break it out another way and show it. Do you remember, Nasser? I think there was another idea somebody around this table had for us about displaying that number.
Yeah.
Well, I think also
Yes, in the board
earlier,
study session.
yeah,
Yeah, good memory.
earlier today in a meeting, I'm going to acknowledge Sheila had referenced the benefit of potentially breaking that out by our funding sources, by Medicaid and Healthy
Okay.
Michigan, and yes, so excellent point.
Yeah,
and
I don't know
think
if we
there
need
is
to dive
value
into
there.
it every month, but I think from time to time, it is just such a overwhelmingly large number. Nasser, you got the answer? No?
No.
Go ahead.
No, I'm good. I'm here if you have any other questions.
Well, I think based on what Dana said at the study session, we got into it a little bit. So maybe quarterly, we kind of dive deep into it. It's just so we have a better handle on what's driving it. Not to get into the weeds, but just so we've got that. So, okay. Any other questions for Robert?
Can I add one thing, Mr. Young,
Absolutely.
too? The other thing is the last 4 or 5 years, I think, is the biggest challenge for us because that's where we saw the greatest loss. And so going forward, if you look at one of Robert's charts, it's pretty steady now.
Mm-hmm.
And our plan is really to make sure that people are in the appropriate category, but also looking at how we're using our general fund dollars. Because like Robert's saying, that's really a problem area. And in other places, they develop a general fund benefit plan. So it really says a lot when you have to limit the plan based on your priority to serve. And so we don't want to do that, but if we deplete our general funds, we would only be able to serve those individuals when they get in crisis. And that's not, we know, a good way to keep the community healthy. So we don't want to do that, but we do have to better manage our use of general funds. And so it goes to the overall management of those various funding sources and how we apply them.
Okay. All right. Thank you. Okay. Seeing no further questions, we'll see you next week at the board meeting.
Thank you.
All right. So we haven't had any contracts for a while, so of course today we have several. Suzanne, you have the first two. You can start us off.
Come on, this is the fun stuff. Advertising, community outreach, right?
Absolutely.
All right. So the first contract that I'm presenting is actually the Surge Grant advertising. So that is a SAMHSA emergency response grant. And we received $200,000 to do some community outreach and advertising. It is going to be countywide, but it also is going to be a little bit more targeted to the Rochester Hills, Troy, that vicinity, those communities. This is following the crisis last summer, the shooting last summer in the Rochester Hills community, and this advertising, this outreach is a little more targeted towards that community. So we have a number of contracts that we're doing. So we're doing multiple advertising venues. You can see that we are working with we already have some cable contracts, so we are tapping into our cable television, as well as we've done some, we plan to do some direct mailers. There are a couple of malls in that vicinity that would have some of that traffic and that community going to it. So we'll be doing some mall advertising, which we've also done those in the past with our SUD team. Also, we'll be doing some Metro Parent magazine advertorials, and also working with our radio and television partners to try to do some more social media type of advertising. As you know, some of that advertising is a little more costly, so we might be doing more social media type of advertising, as well as some theater ads. There's a couple of theaters in that vicinity as well, so we are going to be targeting some of our theaters in that area, and then some of the local papers and doing some publication advertising. So that is the intent, to kind of do a variety of different advertising in that community. We're also working with the Rochester Hills community, the local government, some of our contacts there, and trying to do some outreach with them as well, so that we're connected with them, and also in the talks in terms of ideas, in terms of remembrance and doing some sort of a connection and partnership with them related to a remembrance in the summer. Any questions?
Okay, questions? Finance Committee, other board members? Those local newspapers in that area are amazingly well-read, and I can't explain it, but people will make it all the way through them, so it's worthwhile to do. All right, if no questions, can I get a motion for approval?
So moved.
Second.
All right. Sheila, any other discussion? If not, Sheila, roll call on this one?
Dr. Giles?
Yes.
Pastor Jones?
Yes.
Dr. Guadalupe? Yes. Mr. Young?
Yes.
Motion carries.
Thank you. All right, Suzanne, you back up with WDIV, WXYZ.
Yes, and as you can see, this is some ongoing advertising. I know many of you have seen our commercials over the last few years, or last 3 years. We had a 3-year contract with both Channel 4 and Channel 7, and we are basically wanting to continue that contract. So for a 3-year period, to continue our advertising, we did look at some cost-saving measures to try to reduce this a little bit. So we did determine to reduce that contract by $10,000 per year for that 3-year period. So the total contract amount is $240,000, but again, it's going to be $40,000 per year per entity, so per channel, so $80,000 per year over that 3-year period. And again, it's the same messaging that you have seen those commercials, and I'm happy to bring those forward again. They are actually we get a lot of compliments about the commercials. People do see them, but it will also be that broadcast television as well as the digital presence with social media and on their websites.
Okay, any questions from Finance Committee?
I don't know if it's a question. Not a question.
Would you like to appear in one of the
Could
commercials?
you do this?
That one?
Okay.
Yeah.
Excuse me. There we go. How's that? Okay. It's not a question. It's just really a statement. Maybe there's a statement and a question. Number one, because I think that you do a great job of the promotion, advertisement, of OCHN and all that it does, and reaching out to these other areas that can help us with the promotions. That's number one. I guess the question I have, because when I speak of OCHN, I speak of CNS, Easter Seals, and all of that. Do they share in the promotion or like joint promotion in relation to what we're doing? Because you do an excellent job of talking about all of the service, the outreach. And I'm just wondering, bundled advertisements like I see on TV, Go For It, okay? And it's the Gilbert Foundation and whoever, okay? And so I'm wondering, are they joining in with us, or is there opportunity for that to further spread the great work that you guys are doing?
We do connect with our PR partners from our providers, and there's awareness, and we talk about the different marketing. We try to do as much together as possible so that we are sharing it across the network, so that they're making the individuals that they work with aware of OCHN, and then we're also making individuals aware of the great work that we do. So we do try to connect with our PR partners across the provider network.
Yeah, okay. Because I think, with what you do to getting the word out is just unbelievable, okay? And I'm just wondering, I guess I'm looking at the stretch.
I think that's, given the budget challenges that everybody's in, I think working on the PR side of the empire is probably more prudent as we're talking to all of our funding sources for more money, so.
She does a great job.
Yeah, I'm not denying that. I'm thinking of the other optics. So, Dennis.
I know I probably haven't seen all of them, but in general, they're focused on that we're an organization that can help people, and if you need help, to contact. Do we have any, though, with respect to drug awareness and fentanyl or anything of that nature? Do we have anything that touches on that issue?
Yes, absolutely. With our Comcast cable contract, we do a specific advertising, specific commercials for SUD that are prescription drug awareness, alcohol awareness. So there are specific commercials that are developed and put out. There are specific months that we do our advertising on Comcast Cable for SUD, the SUD side.
All right.
And there's funding that's targeted, that's used just for that.
Okay, I don't do Comcast, so that's probably why I didn't
Okay.
see it. But could you send those to us, just so we could see those?
How about if I post them on
yeah,
Boardable for you?
That would be great. Thank you very
Yep.
much, yes.
I'd love to do that, yeah, no problem.
You know, kind of along these lines, it might be helpful on Boardable to, I mean, because you have billboards and just things where the board members can
Yeah.
find them rather than quizzing you every time these things come up. So I think it would be good to see as I cut through Pontiac, I see a lot of the billboards, so there's quite a variety of them.
You know, you're on a good point there too, John. For the board getting that, but also for the board to share that. You know, I have a comment about a group that worked with me today. I'll do that at the comment time, but sharing that information. You know, all of us are engaged with certain groups, organizations, or what have you, and good for us to say, did you know? So, because I tell you what, with the reach that our group has, and thank you, Suzanne, for what you do, you reach a lot of people, and I really believe that we can help with that reach.
Great idea.
Yeah, I'll just make mention too, our commercials actually are on our YouTube channel, but I'll go ahead and make sure I add those links on Boardable for all of you. But anybody else that would, from the public, would like to see our commercials, they are on our YouTube channel.
Very good. Okay, thank you. I need a motion for approval.
So moved.
Second.
Second, all right. No further discussion. Oh, there you go.
Thank you. Suzanne, have we looked into putting ads on the app next door?
I've heard of that app. I will definitely look into the
Yeah.
cost for that.
It's a really popular app in suburban communities. So I think that'd be a good place if we could afford it, if we have
Great
funding
suggestion.
for it. Okay.
Thank you.
Thank you.
Good suggestion. Okay, Sheila, roll call.
Dr. Guadalupe?
Yes.
Pastor Jones?
Yes.
Dr. Giles? Yes. Mr. Young?
Yes,
Motion carries.
thank you. All right, Kalana. Thanks, Suzanne.
Hello, everyone. Kalana here, Senior Counsel for OCHN. I have a small echo, but hopefully you all can hear me okay.
Yes.
Great, thank you. What I'm presenting tonight is our CMHSP contract, Amendment 1. This contract runs for the entire fiscal year. The original contract amount is $10.8 million. This amendment is not a funding change, rather is a modification to our terms related to our reporting obligations. Some of them require additional reporting obligations. Some are just changes that have occurred through the different work groups across the different CMHs, excuse me. This will not affect funding under our agreement, but I'm happy to answer any questions. I believe you have more detailed information about which sections of the agreement were modified in your packets, but overall, these are just programmatic changes.
Any questions first from Finance Committee? Other board members? Kalana, are there any of the sections that are listed that are more major change, or are they more just updates?
Some of them do present some critical changes. However, the different work groups have worked through those and have discussed how to implement most of those changes prior to those being added to the agreement itself. Some of them are just grammatical updates. Some of them are actually programmatic or reporting requirements that have we've had to adjust for.
Okay, all right. Thank you for the clarification. Can I get a motion to move this forward to the full board next week?
So moved.
Second.
Okay, any further discussion? Sheila, roll call on the contract.
Yes. Dr. Giles?
Yes.
Pastor Jones?
Yes.
Mr. Young?
Yes.
Motion carries.
All right, thank you. We'll hear from you again next week. Last of our contracts, Stavo, Trish, My favorite piece of software.
So this is our Docebo Learning Management System. I am covering for our Director of Training, Jean, today. This is a 2-year contract, so it comes up for renewal every 2 years. If you remember some history behind this, we brought training in fiscal year 22, 2023 in January for our direct support professionals. So prior to this, we were contracting with TTI and with MORC for about $1.5 million total for this training contract. So now we have it in-house. We have a few staff who are dedicated to this, and we have our learning management system. So this contract this year, we will be increasing our monthly active user from 1,000 to 1,500. We are going to begin to transition our other populations onto Docebo, starting with SUD and moving towards our other populations as well. We do consistently pay an overage every month, so this will actually be a cost savings for us by increasing to 1,500 monthly active users. And if you guys remember again from history, a person can take 1 training or 100 trainings in that month, and we're only charged once for them. And most people do get their trainings done within a certain period of time. So this will be a 2-year contract beginning April 1st and then through March 30th of 2027.
Okay, thanks, Trish. Any questions from Finance Committee? Other board members? So Trish, I got one. When it talks about the DSPs, is that all the DSPs that work for the companies who we pay, or how broad is that?
Yes. So all of our direct support professionals, which is almost 8,000, are on Docebo. Those who work with those who are self-determined may choose to get training elsewhere, which as long as it's vetted through our state training guidelines, we will accept training elsewhere. But that is probably the majority. There may be a few that are not on Docebo, just that they choose to get trained through Detroit Wayne, their Connect system, but the majority are on Docebo. So we've definitely, when we launched this on January 1st of 2024, for the DSPs with the full curriculum, we are now up to almost 8,000.
Wow, very good. Okay.
Can I ask one quick question?
Sorry, yeah, absolutely, sure.
You had mentioned that it is going to expand out to others, so I'm just wondering, could it open back up so we don't get overages again, or is this stuck in, like if you exceed the 1,500?
We can always increase. I can't go down.
Okay.
So if throughout this 2-year contract, if we notice that we need to move up to the next step, we're able to do that. We usually see how much we go over, and we make sure that it makes financial sense to move up to the next one. So, yeah.
Thank you.
Okay. All right, can I get a motion to move this forward to the full board next week?
So moved.
Second.
Any other discussion? Sheila, roll call.
Pastor Jones?
Yes.
Dr. Giles?
Yes.
Dr. Guadalupe?
Yes.
Mr. Young?
Yes.
Motion carries.
All right. See everybody at the meeting next week. So we'll shift gears to policy management, and Christina's going to take over the meeting now.
Thank you. This is Ms. Root, Vice Chair of the Policy Committee. Our Chair, Ms. Woodruff, is not here tonight. I believe we just have one item on our agenda. Adam Hamilton, if you'd like to come up.
Okay. Good evening. Thanks for having us tonight. I'm Adam Hamilton. I'm the clinical director here, and it is my pleasure to introduce to you Deb Monroe from Hope 365. This is a program that was, grant funded for a while, and then we have, recently had some successes in being able to reopen this program and keep it going. So we're going to talk to you a lot about that. But let me turn it over to Deb and have her just tell you a little bit about her background, and then we'll get into the presentation.
All right. So my name is Deborah Monroe. I'm a certified peer support specialist and recovery coach. Started working at a crisis center and found out really early on is that individuals, when I was working with them, would find out that they felt like there was either I'm doing well or I'm in crisis, and there was nothing in between. And so I started doing some research and finding what other states were doing, and they talked about respite, and so I went and visited some of those places and wanted to bring it back here to Michigan. And so I've been on a crusade to get it open, and so in 2021, we were able to finally secure funding through OCHN to be able to open it up through a grant, and we were able to keep it open until 2024. And we're going to talk a little bit about that. So.
All right. You can go ahead and advance the slide deck, please. Thank you.
All right. So Hope 365 is a short-term program. It is 1 to 7 days. Sometimes we may, if a person is working towards a goal and may need to stay a couple of days extra, but usually it doesn't go over like 8 or 9 days if they need an extension. It's usually 7 days. We did have the capacity for 7 beds, but because of the need and the resource that people want to utilize it, so we are now an 8-bed respite. Again, it's completely run by peer support specialists or individuals with that lived experience. And, what we do while we're there is that individuals have the opportunity to look at learning new coping skills and also helping them create a wellness plan while they're there and also a crisis plan so that they can recognize symptoms in themselves, take personal responsibility for their recovery, and then be able to utilize that when they leave. We help them with resources. We get individuals with different needs. Sometimes it is housing. Sometimes it is just getting entitlements or documentations that they didn't have. Helping them utilize entitlements that they have, like Section 8 vouchers, because they've had the voucher for a while. It's getting ready to run out because they don't know how to use it, and so we help with those things too. And then, again, is that we focus on like different activities, whether it be in the community or at the house. We provide sometimes yoga, having people come in and do yoga. We do things out in the community, like, weather permitted, they've went to the beach for the day, and we work on just finding things to do that help them get outside of just thinking about their mental health symptoms, but being able to engage in activities, stuff like that. Anytime we have resources where we can get involved in different things, that we want to make sure that we get the guest involved too.
The slides.
So again, we were awarded a grant in 2021. It was October of 2021, and we thought that the biggest barrier for us was finding the money to be able to open this. We found that there was a lot of barriers. One of the barriers that came up in 2021 is that we had to find a location. And a lot of people were like, not in my backyard. And so it took a little while to find a home that we could use because we wanted it in the community. And for us, the environment was really important. We wanted a place that someone could come and just not have to worry about what the environment looked like, but be able to come in and just relax and focus on their wellness. So we were able to find a place. We had to do some remodeling, some construction to it, and so we were able to open up March 1st of March 1st or March 2nd, but we were able to open up March 1st of 2022. And from March 2022 to March 2024, we had money left over from our grant, so we were able to continue that until October of 2024, also with the support of OCHN. And during that time, we served 487 individuals, giving them support and helping them with their wellness. We closed down the October 1st or October 15th of 2024. We weren't sure if we were going to be able to reopen because we didn't have secured funding to open. So we worked with community partners, different providers in the community, the CCBHCs and OCHN, and we were able to secure contracts so that we were able to reopen. Our first day was last Monday. Within 3 days, we were completely full and have a waiting list of like 5 people right now waiting to get in, and we're utilizing all 8 beds. Next slide. You know, most of the guests that are referred by, you know, our provider agencies, OCHN, and community-based services, make up the majority of the individuals that we serve. We do get individuals that self-refer. So they may see our flyer in the lobby of an organization or somewhere in the community where we've been able to place them, and they will self-refer. And then also we get step down from hospitalization. So an individual may be coming out of a hospital setting, needs that support to transition back into the community, and so they can come to us. We help them. And, you know, one of the things that I thought was very interesting, because I don't know necessarily what people may get from, you know, our support or services. And I had a young woman step down from hospital, and I asked her, what is it that you get from us as a step down? And she said, well, if I left the hospital and went back into the community, I'm being put back in the community, and I don't have the resources to, you know, I have to get connected with my case manager, I have to get groups, I have to do all of this stuff at one time. And a step down to you is I still have those groups available to me, which were really helpful for my recovery, and then I'm able to connect to the people and my supports and transition slowly back into the community within those days so that I don't find myself back in crisis. So we have those three different ways that we get people for our program is like I said, those referrals from the providers, self-referral, and then hospital step down. Next slide. I'm sorry, I can't see that, so I have to look at eyesight's bad.
So this slide really shows that, we looked at some data during the grant period, and we were kind of trying to understand what is the impact that Hope 365 is having. And what you can see in this slide is that the vast majority of people who participated, who were guests at Hope 365 and participated in the supports there, had significant reduction in the amount of inpatient, crisis residential, crisis services. I think we have emergency department use on there. So, you know, in the period after they were a guest at Hope 365, the utilization of those services decreased, and they were able to, you know, maintain with outpatient services and other supports that they had in the community.
Yeah. So one of the things that we wanted to do is see if if what we were doing was making a difference in people's life, and so we connected with the Human Service Research Institute out of Cambridge, Massachusetts, and they helped us create a database to be able to collect data, to collect the data that we needed. We weren't sure what data we would need, so we collected a lot of it. And then what happened was we looked at individuals that were, like one of the questions that we ask individuals is how often were you in the hospital 1 year prior to coming to us, during that 1 year, and then, and then they come to us, and then we look at look at that data once they leave us, and how often are they using the hospital or CRU emergency room or day program, and we were able to show through that data that there was a huge reduction in those services. Next slide. And so here we show, like OCHN provided has been the biggest source of, like I said, referrals. And, here we talked about, so here were some numbers that we were able to collect, and I think it was our first round of data collection because we've done 2 now. And there was 85 people saw a decrease in inpatient services. 119 individuals saw a decrease in the CRU services. 142 individuals saw a decrease in crisis contact, and 92 individuals saw a decrease in the ER visits. Again, we've assisted individuals, like I said, with their mental health. Some have co-occurring disorders. We're able to help them navigate supports and stuff like that as they need it.
And I'll just add that, for our provider network, you can see what an important resource this has become to them. It's a great option for referring people who maybe want to take some proactive steps to avoid going into crisis. And though it wasn't utilized as much for this, the option for step down from higher level of care is really excellent too. And the data bears out that it does reduce recidivism. So. Yeah.
Well, a lot of times too is that people may have to wait until they are, if the hospital is the only option, then they have to wait till they get sick enough to access those services. And so that could be weeks. And so we can catch them early on before it gets to a crisis, reverting that. We're diverting that crisis and being able to help them move, just keep moving forward in their recovery journey. The other thing is that, individuals we will get individuals sometimes, and sometimes that's why you don't see like 100% of decrease, but sometimes we get individuals and they may need more support than we can offer them, and so we're also able to direct them to other services that more appropriately can support them at that time. Next slide. And so this is just, one of the, things that we asked them is, was like recovery focused, was the services that they received recovery focused. I know that in 2009 they did a survey and asked people, did they know about recovery from mental health? And there was when the data came back, it said that individuals had not heard about recovery or that no one had talked to them about recovery. And so one of the things that we want to focus on is that recovery. And you see there that, I can't see the data, that 67% of individuals said that the recovery focus, of those services. Next slide. Here we capture what, the impact it has on individuals. And some of the things that we've heard from individuals that have been at our services is like, one day we took individuals to the movie, our guests to the movies, and we asked them, how many of you thought about your mental health symptoms while you were there? And we had one gentleman tell us is that this is the first time in a really long time that I've been able to laugh out loud in public and feel normal. And so, if you get, and we talk about the importance of getting out and getting involved in community activities and, and giving back and stuff like that. We've had we had a mother that was, felt guilty about coming to our program because she said she has kids and she has, she has a spouse that she's the caretaker for of all of these individuals. She said, but at the same time, she needs help. Like she is having a hard time taking care of herself because she's always taking care of everyone else. And so she said she felt really guilty even thinking about coming to our program. But again, she said she needed that support because if she's no good to herself, she can't help anyone else. And so we're finding, like sometimes too, is that, people that are, they're struggling with their own mental health, but they also have, taking care of others. And then we also had someone share with us is that, like they wanted to give up, but it was, that we were there to help keep them going. And we capture those type of, when they write that in our surveys and stuff, we capture all that data. But we, we've had individuals will come in and they'll say, can I go out and smoke? And I'm like, why do you have to ask? You're an adult, you get to make these choices for yourself. And so people are there and they're involved in the process. They get to decide what goals they want to work on and what they would like to do while they're there. And so we're there to support them. We make sure that we make space for for that whole person, whether it be, feelings, emotions. We're just there, open-minded, non-judgmental, and be able to meet that person, as they are when they come in. Next slide. And this is just another part of our survey, was just strongly agree, and there were some different questions that they had. And as you see is that, that data reflects like, they felt like, and I'm sorry, I can't see, this is really small. Did they have choice? Did we honor and respect the individual? Did we focus on what their needs were, things like that? Because part of that data too is we wanted to make sure that we are not harming the individual, but are we providing respect, support, in the way that they need it. And so there's questions on that because we do an entry survey and we do an exit survey. And we want to make sure that we are providing the support and services that's going to benefit them while they're there. And the next slide is just questions.
Thank you so much. Are there any questions or comments from policy committee members? Dr. Hans?
So I'd like to know what kind of staffing is required for this, and it's a grant-funded project. The staffing for this service, it's very well needed. You are at capacity now, and you have a waiting list as well. Mm-hmm. So obviously there is a great need for this in the community. So I'd like to know how does the staffing for this project work, and also the funding in the future. It seems like it's needed in the community, so.
So we are the first respite here in Michigan. Oakland County has the first peer respite. And so we are all certified peer support specialists. We all have to meet the criteria for training through MDHHS. And those requirements is that you are a person with lived experience in recovery, willing to use your experience to help other people. And again, is that we find peers not all peers are fit for this setting, because this is a part of it's a part of the crisis continuum, right? And so we have individuals that are not always at their best, and so we talk to peers that want to work in that setting, and you just have to you find those right fits. As far as funding is that, like I said, we were grant funded in the beginning, but grants don't always last, and so we had to close down because of those grants, and we weren't for sure if we were going to be able to open that up. We were going to be able to open it up, but when we closed, we were able to have data to show that our program worked. We were able to, we had providers that were calling to find out, like when we were going to open back up, because they were utilizing our services. The individuals that were coming to our services were, like still calling and finding out when we were opening, and we weren't for sure, but we were able to finally sit down with the providers and build these contracts so that we could open back up. Yeah. We are hoping to, though, one day get it into the Medicaid manual, that we will be able to have, there's a per diem for respite when it comes to the caregiver, but there is no per diem in the Medicaid manual for the type of respite we have. And so we're hoping that in the future we'll be able to have a code in the Medicaid manual that would be able to allow for continuing funding, and then even to see more of these in other communities.
Questions from other board members? John Paul?
I'm not sure if you mentioned, but how long is the program?
It is 1 to 7 days, and so some people may only need a couple of days, others will stay up to the 7. Some people have even wanted to move in.
What's the average stay?
The 7 days.
7 days. And then, where is it located again?
It is in Rochester Hills.
Okay. Thank you.
So right off Crooks Road.
Okay. Oh, and then referred. How are individuals referred? Is it self-referral or?
Well, we want to talk to the individual to make sure that this is something that they want to do, because it's voluntary. It's not something that's mandated. And so we talk to the individual to make sure that this is something that they want to do. Now, they get the referral. They may get the information for their case manager, the agency up here, and or at the hospital that they're at, or something like that. But then we talk to them, and we go through a phone screening process to make sure that they're eligible, because our criteria has changed a little bit. We used to be able to take anyone that was in Oakland County when we had the grant, but because now we have these contracts, they have to be connected with an open case with the providers.
And have you guys received any pushback at all from the community?
No.
Okay. I know, unfortunately, sometimes that happens.
Sometimes that happens, yes. Now, we've had it a couple of times where, like we've had to have engagement, but we're working with like the mobile crisis unit in case we needed like something like that. We try to be as discreet as possible. We do have neighbors, so we respect their space also. And we haven't had any like the neighbors haven't complained or anything.
Excellent. Thank you.
Yeah.
Dr. Guadalupe?
Yeah, I just had a question. Not that you, obviously with waiting list and everything, it's hard to get more referrals, but I was just curious, with the hospital referral being, I think it was only like 2%, 1.8% or something, is there marketing that hospitals are aware of your service?
Not all the hospitals are aware of our service, and when we started, we were doing some marketing, going to events and putting out our flyer and giving out our information at the agencies. But we got a lot of referrals that way, and then it was word of mouth too, that people would share that they had utilized our services and stuff like that. We want to be able to go out and market more to all of the hospitals, because we have worked with hospitals that we may, because if we have someone that may need hospital services, and they'll be like, oh, what do you guys do? And they're like, can you talk to our team? So it's another resource for them, so yes.
Yeah, for sure. No, it just sounds like a great program and would be a very good step-down option. Again, limited with the amount of beds, so as you market it more or folks find out more about it, I'm sure.
Yeah, so we
demand will increase, which will be difficult, but,
right.
Yeah, thank you.
Yep, thank you.
Ms. Newman?
Congratulations, Deb.
Thank
I know
you.
this has been a long time coming. And like you, I've been wanting to see a respite in Michigan for years. I've gone to peer conferences all over the country and sat in on those sessions, and I'm like, this just makes good sense. It makes good sense. Why aren't we doing this? And
Yeah, I had been working on this almost 13 years. And, every year it was like, it's just not a good time. And so I almost gave up that last year, and we've seen that, because of COVID, that a lot of individuals that may need those services was not getting into services because beds were filled with COVID patients. And so, we tried it one more time, and it worked that time, so.
Congratulations.
Yeah.
Pastor Jones?
Thank you. The question that I'd like to ask is, the persons who are providing the services there, I think you mentioned certification.
Yes.
At our solidarity meeting, we talked about social workers, psychologists and all having to be certified or recertified, and there's a cost to that. Are you running into a need for support issues for persons who are trying to pay the cost of recertification, the test for that, or what have you? Is that something that you run into or not, or?
So one of the things is that OCHN actually does some of the state trainings, and for anybody that works or lives in Oakland County, some of those trainings are free to them. So they're able to get their CEUs to be able to continue their certifications, which has been really helpful, or it's at a cost that we can afford.
Okay.
Yeah.
I'd like to talk to you about that.
Okay.
Thank you.
Dr. Giles, did you have a comment or question? I thought I saw your hand. Yeah? Okay.
Thank you. I was just waiting. Again, as you know, the service much needed, so congratulations on getting it done. I heard you say that some of your referrals come from hospitals. With that, I was wondering, how are medications handled? Do the individuals there, the people served there, handle their own medications? Are there stipulations, no controlled substances? Just wondering how that is handled.
So what we do is that because we are peer support specialists, we're not like nurses and stuff like that. We don't handle any medications. And one of the questions that we ask during the phone screening is that, are you able to manage your own medications? So when people bring in their medications, they're given a lockbox that they take to their room with them. They put their code in there. That's their lockbox while they're there. It's locked. And so they manage their own medications. But one thing that we've learned is that they may have been taking them while they're at the hospital, may not want to take them while they're there. And so we ask people, do you need support with like reminders and stuff like that for your medication? So we can put reminders on their phone. We don't have the ability, because if there's 8 people in the house, we have 2 staff. We can't say, oh, right now it's time for medication, because there's Monday through Friday, there's a lot going on. And so we try to find ways to remind them to take their medication and stuff like that, teaching them how to do it, take personal responsibility for their wellness.
Thank you. One more question with that. Coming out of the hospital, a lot of times we like to have those individuals seen within a week after discharge. I imagine 7 days in the program. Do you run into issues where you have to assist those individuals with getting to their appointments with psychiatry within that week or within those 7-day limits?
So in the past, not everybody was connected to a provider, and so we were able to either help them sign up and get connected to providers, now they are with a provider. We encourage them to stay connected, and so that's what they have access. We have iPads that people can use if they need to do telehealth. They can go to an appointment. Sometimes we might not be able to provide the transportation because, again, we only have 2 staff per shift. but we encourage them to use the back of their Medicaid card for transportation to an appointment. We can also help them, like, if they make an appointment ahead of time, can the agency come and pick them up? Or the agency provider can come to the house and meet with that individual. Because we want them to stay connected to those services, while they're there and when they leave.
Thank you.
Thank you.
Yes, Ms. Newman?
Just one more question. I thought when you first opened up, it was only for substance use disorder.
No, it is mental health. What we found is that when we opened it up into the community, is that a lot of individuals they were either co-occurring or they had substance use disorder. And so, working with them, it was either, helping them find out what resources they may need, whether it be a treatment program or getting connected to community mental health services because of a co-occurring, they're dealing with their mental health and their addiction. But now, the way that it's set up, they have to be with a mental health provider. Yep.
Okay. I don't have any questions, but I do want to say thank you for not giving up. I hope that this grows as a model because we know that community connection in the least restrictive environment as possible, it works.
Yes.
I'm a mental health therapist, and I haven't publicly shared this, but I've had my own mental health hospitalizations. And I was just recently talking to someone saying how I wish there was a place where you could go that was between therapy and hospitalization. So thank you.
Yeah, and the other thing is that, a lot of times people don't want to disrupt other things that they got going on in their life. And so if a person comes, they can still work if they choose to. They can, they have family members pick them up and they may go out on an outing with their family member and then, be brought back. We've had individuals, like today, we had someone go to their appointments in their group and then come back, and so again, it's not restrictive where, because we want them to stay connected to their support systems and the resources that they are already utilizing in the community.
Thank you. Sheila, is this a voting thing? No. Okay. All right. Thank you.
All right. Thank you.
All right. Thank you. That was would fit into our board category of stories that inspire hope. Okay, we're on to item 4, other business. First one, events and outreach. Suzanne, come on back up.
Hello, I'm back. Just wanted to bring your attention to quite a few events that we have going on in the month of March and coming up in April. Actually, the PTSD and moral injuries of training that was held last week, as well as some conferences. But I also wanted to make mention about the Abilities Awareness event. It was such a great event. I was so happy with it. The room was full, which was wonderful. We had a little scare because our original host wasn't able to make it. But luckily, Josh Landon was able to step in and be our host for the event, which was phenomenal. So he did a great job, and we were able to honor some really deserving individuals. You'll be seeing one of them next week for Stories That Inspire Hope, and hopefully the second one, but I know for sure one of them will be here. And we had a really great presenter, Alex Kimmel, who is the self-determinator. I don't know if anybody has seen him before, but he is hilarious. He has such a great message, and it was just a phenomenal event. You'll see some pictures at the end of my slides. But thank you so much to Malkaya and Mr. Young for coming. It was just really phenomenal, so thank you to everyone. Next, just some other events that we've had some tables at. We had staff some tables. We're also hosting a FMS self-determination forum or webinar tomorrow. Just kind of a little circle back with individuals that are, this forum is for individuals served. Circle back to just give them some updates of how things are transitioning, and then just some trainings coming up. Next slide, please. Also, just some events that we're attending. I'll be attending the OU Healthology event that is coming up this week. We'll have a table there as well. We've got some additional trainings. We have some staff. We have a table at the ARC Dove Awards. We actually nominated an individual served who is actually a recipient of the Dove Award. So we have a few staff going to that event this week. As well as we have our customer service team presenting at the Bowen Senior Center about mental health in older adults. And then some conferences that are coming up that we have staff attending, Dana is attending, and then actually Kim Flowers is going to be on the panel for the, it's called Talk, which it means the Unity Collaborative Women in Leadership Summit that's coming up at the end of the month. So we're really excited for her to serve on that panel. Next slide, please. As you all know, we have the Metro Region Dinner coming up at the end of the month. And then just to highlight a couple things that are coming up in April, there'll be plenty more when I present in April. But I did want to note our Behavioral Health Job Expo and resource event. We have almost 50 vendors that are coming, and this is an opportunity for students to come and actually interview for behavioral health positions. There are resources that are going to be there. So we're really excited. It's being hosted at OU again. This is our second annual. So we're looking forward to that coming up on April 1st. And then some trainings, and we have some other events that we're going to be hosting at table. Next slide, please. Just to bring your awareness to some of the press releases, obviously our Abilities Awareness event, press release going out, also observing the National Drug and Alcohol Facts Week, and then announcing our managed care director. She's been here for a bit, but we kind of hold up on putting those announcements out, so that'll be coming up soon. And then our ongoing advertising that I've already talked to you a little bit about earlier, and as well as some of the use of our rooms. We're getting a lot of use lately, people using the facility, so we're grateful for that. And the last slide is just some photos of the event last week. So we've got Josh and our two recipients of the awards, as well as our guest speaker, and then Trish with our recipients as well. And that's all I have.
Okay, any questions?
Where is the April 6th suicide prevention walk, and who's sponsoring that?
I believe that is at Oakland University, and we do that. We are actually hosting a table there. Okay. So it's through the Suicide Foundation. I can't. American Suicide Foundation, I believe it is.
Well, if it's at OU, I think I know somebody who can help me.
I'll get you.
There are a lot of things going on at OU lately. Yeah,
busy spring.
It's a busy
Very
place.
busy spring. Okay, any
Thank
other
you.
questions? If not, you have item B as well.
I do. So I'm proud to bring you our May is Mental Health Awareness Month proclamation, as we have talked in the past, and bringing this to you this month because it gives us an opportunity to send the proclamations out to our partners at our local cities, villages, and townships, as well as our school boards and our faith-based organizations and beyond. If there's anybody else you would like to send this to and have them have the proclamation, then we are super happy to go out or provide that. So this is the proclamation for this year. I'm happy to read it for you if you would like me to.
I think we all read it, but yeah.
All right.
Yeah,
And I will
but
not-
but I do have. Can I?
Yeah, go ahead. Yeah.
So I'll put this out in a memo to everybody. But I've been thinking about this for a while, and I'm just going to ask the board if you're comfortable in the community you live in. If with Suzanne's help, we could contact that local municipality and we could go and present the resolution with the mayor or the township supervisor. I'll do that in Royal Oak. So I'm the one who came up with the idea, so I'll open my mouth. But I just think it might be a way get us a little bit out we're all out in the community. I'm not, but it just might be an interesting twist, especially with mental health, to help raise that awareness. So I'll put a little memo together to everybody, and I think they'd actually welcome having somebody show up. Now, there may be some local groups that also come that may be headquartered in their community or something of that nature, but we can at least make the offer that a board member could come. And again, it's only if you feel comfortable doing it. Obviously, that's my second nature, my prior job. So I think that might be something we could all get out and do. Yeah.
I'll just add that usually our staff goes, so
Good.
You don't have to go alone. That's what I'm saying. If you go, we can send support. I've gone, Suzanne's gone, communication staff, so.
Yeah. And by the way, we have an awful lot at almost every township board meeting or city meeting is the police chief and they all know who we are because of the crisis intervention. So it won't be like OCHN will be unknown, and a lot of the cities and communities have interface with us, and know a lot of the staff members. So it's just a thought. And
It's a great idea.
yeah,
I
okay.
mean, some of them do send the proclamations in, but I do believe it's much more impactful if
Yeah.
we can have a presence in accepting the proclamation and be able to say a few words.
Yeah.
Absolutely.
So I'm not asking anybody to get in a dunk tank or get dumped on with ice or anything like that. I've done that, but if that, I think that's just something I thought. What would be something that would be something we could do jointly? And I think this is an excellent one to provide some backup to this awareness program.
Great. I have you down for Royal Oak.
Okay. All right.
We set
Well,
the precedent.
I said it. Now I got to do it.
Yep. Thank you so much.
All right, very good. All right, any other questions?
Quick question. The metro region, it's probably in Boardable, but is that in person, online, the metro region on the 27th?
It's hybrid, so
Oh, okay.
Yep.
So we're here, and then others are online, or,
either or, you guys can be here or online as well.
okay. Suzanne, you have to worry about
Preferably
this.
here.
So we're here? Yes? No? We're here?
Dana will be remote if she can, because she's traveling.
Oh, that's what I thought,
Yep.
okay. Trish will be here? Oh, all right, Trish is here, I'm here. All right.
I'll be
we're
in
good.
person
Okay.
as well. Yes, I'll be here as well.
Okay, all right, so we'll have several folks here and some online. Okay, thanks, Suzanne.
Thank you.
All right, we're back for our second opportunity.
Can I get a vote to move the proclamation forward for approval?
Yeah, thank you, sorry about that. All right, so I need a motion to move the May's Mental Health Month proclamation to the full board next week.
Support.
All right, any other discussion? Do you need yay, nay, or do you need roll call?
Yay, nay's
All
fine.
right, all those in favor, say aye. Aye?
Aye.
Any opposed? All right, take it to next Tuesday. All right, so now we're off to item 5, our second opportunity for public comment. Anybody online?
If you are online and wish to speak for public comment, please raise your hand at this time.
All right. Anybody in the room? Okay.
Oh, anybody in the room? I thought you were a board
No,
member. Sorry.
no.
I apologize. No.
Looking to the studio audience. All right, item 6, board member comments. We'll start with Dr. Hans and come around the room. Okay.
I do have, and want to throw this out as a compliment to the work of the staff here. Over the last few weeks, we've had several of the organizations that are tied to OC and Oakland County Health Network participate in meetings with our program of Timeout and within the Greater Pontiac Community Coalition. Today, Tradina Taylor spoke to a group, and she really talked about mental health, the services that were available, assets available for persons who may be suffering from either mental health, suicide, drug addiction, or what have you, and she did just an excellent job. She spoke with our Timeout group, which really proved to be a very effectiveness because they reach out to other persons. So that was number one. And then 2 weeks ago, we had the support of OCHN in a discussion regarding Chance for Life that was presented to the Greater Pontiac Community Coalition board and members, and that also was very well received, and I tell you what, a lot of responses from it. And so I want to thank the staff. I want to thank the staff, and in particular, Trish and Suzanne for the work that they have done in pulling those groups together to help us get the word out. Whether it's for returning citizens, whether it's for the average Joe or Mary Joe that's walking up and down the street that's saying, what is available? For us to be able to get that information out is very, very helpful. I learned today that one of the organizations that we have is not in the Pontiac schools. And we have such a high incident of mental or violent abuse going on in our school system. And, you know, to learn that was just really a surprise to me. You know, my plan is to meet with the school district and talk to them about it, about the services. And that, again, is why I say if we hear something, it's good for us to pass that word on. So to the staff, to the leadership and the teams, thank you very much for the people that you have. But even more than that, thank you for the services that they provide.
Yes, I just wanted to mention, this past Monday, I went to my church, Shrine of the Little Flower in Royal Oak, had a presentation by the Fentanyl Fathers, which is a group that goes to high schools in Michigan and attempts to reach the most vulnerable in that age group, because 14 to 21 is the age group that gets hit the worst with the fentanyl deaths. And it was an amazing presentation. Both gentlemen, unfortunately, had lost sons, and they shared that. There were others who were there. They've done 45 presentations this year. Think about that. There's only been about 70 days in the year. And they were going to Royal Oak Shrine and another high school the next day. So they like to go and have an opportunity to speak with parents the night before. And in addition to an outstanding presentation, and I urge any of you, if you have occasion to go, to go. The other point I wanted to make is there was a representative there, and I did not get her name, and I really regret it. I will get it from the, I believe it's the Alliance of Coalitions, and that is the group that we have funded for the life safety boxes that are in Oakland County. And I got a chance to talk to her, and what we did is saving lives. There is not even any question that that's saving lives. Just that making the Narcan available, and that was the other thing. They were giving the Narcan out at the meeting. I took it. I don't know. It's just not taking it. You could be exposed to it too, and so I hope I never have to use it with anyone. But they were making it available, and I would just. It was such a well-done program, and it made me feel so good about what we do here and the support that we give to the community and to the kids especially, because as this gentleman said, you only get one mistake with fentanyl, you know, and then that's it. And so I would urge you, if you get the chance to go see this program or any program, but this one in particular, and I am really pleased and hope we'll be able to continue to support the life safety boxes that we have around the county. So that's it.
Okay. Hard to see down there. Melchiah?
No comments, thank you.
Okay. John Paul?
No comments, thank you.
Sarah?
No comment, thanks.
All right. Dr. Giles?
No comment, thank you.
All right. So I'll channel Adam since he's not here. Thanks to the staff for the presentations. Everyone have a good night. There's been no further business. We stand adjourned.
Sorry, I've been so out of it this past week. All right.